The last guidelines for management of systemic lupus were released in 1999, and a lot of things have changed in our management approach since that time, and the landscape of therapeutics in lupus have changed a lot. So now we have a lot more robust evidence on treatment strategies for lupus nephritis. We have two new FDA-approved biologic therapies, so belimumab and anifrolumab, that have been released since that time. And I think there's also an increasing recognition of parallel comorbidities that we need to think about in management of SLE, like heart health and cardiovascular risk, bone health, and other lifestyle and comorbidity management. And so that's also reflected in these new guidelines. So the new ACR guidelines provide essentially an overview of lupus treatment that's separated into different organ systems. And some areas they specifically do not address in these new guidelines, such as management of antiphospholipid antibody syndrome, pregnancy considerations, and type 2 lupus symptoms. They also do not discuss nephritis, since those were addressed previously in the lupus nephritis management guidelines that were released earlier this year. So the guidelines are then broken down with treatment recommendations by each organ system, the specific medication that you would consider for different types of diagnoses within each organ system are also described. So for instance, you could go under the cutaneous category and see specific medications for mild versus moderate to severe cutaneous lupus, and then look at specific subtypes of skin disease. So for example, how to treat bullous lupus versus chilblains versus something like leukocytoclastic vasculitis. The manuscript also has a nice figure 1, which organizes all the organ-specific therapies in their different sections based on the organ manifestation, and that's also, stratified by the disease severity. And then finally, there's some guiding principles that are provided. So assessing disease activity regularly, as well as joint damage at least once annually, and then some guidelines surrounding the use of steroids and hydroxychloroquine. For example, it's recommended to try to get all patients down to below 5 milligrams of prednisone per day, and ideally taper and discontinue once they're in, sustained remission. There are several pointers, I would say, for specific considerations when prescribing lupus medications that the guidelines highlight. The reader can use figure 1 to determine, as I mentioned earlier, which oral conventional synthetic DMARD, biologic DMARD, or IV therapy is recommended for the different disease manifestations. Can also take a look at Table 5. I thought this was a nice addition, which provides lupus-specific medications, including dosing for adult and pediatrics, the recommended laboratory monitoring, and other considerations that we need to keep in mind in terms of monitoring these meds with the management. There's also Table 6 that's helpful for skin and cutaneous involvement. So this lists the topical steroids, as well as which body location you can use them on, like scalp versus face versus the body, and their potency. And then readers will notice some unique therapeutics are also suggested. So consideration of like anti-IL-1 biologic therapy for recurrent or refractory pleuropericarditis. There's also mention of Plex and IVIG that can be considered for life-threatening vasculitis or for severe refractory neurologic disease. And finally, the authors kind of do a little bit of a deep dive into dosing recommendations for glucocorticoids, such as dosing recommendations for IV pulse and oral, and then for hydroxychloroquine. So rheumatologists familiar with the weight-based dosing recommendation of 5 mg per kg per day. But the authors also highlight that there are times in managing SLE where you can use a higher dosage, for example, between 5 to 6.5 mg per kg per day, such as at the start of hydroxychloroquine treatment, to maintain disease control for shorter periods when someone may be flaring, or during pregnancy. So the guideline includes a table, table 4 in the manuscript that suggests alternative and adjunctive treatments for managing the comorbidities that we see in lupus. So this would cover topics such as addressing cardiovascular disease risk, where lupus should be considered as a risk-enhancing factor for example, ASCVD risk calculators. They also talk about some things to consider with infection risk, like infection screening before starting immunosuppressant drugs, recommendations on vaccinations for those that are on immunosuppressive therapy, and infection prophylaxis for entities such as PJP and hepatitis B. There are also sections on guidance for bone health, osteoporosis, cancer screening, and reproductive health. So, for example, the reproductive health provides some guidance on contraceptive use and reminders on conception timing as well as fertility preservation when using IV cyclophosphamide. So these can be very helpful if, managing some of the adjunctive issues outside of the direct lupus-specific therapies. In terms of the take-home points, I would say these guidelines provide a comprehensive overview for the management of systemic lupus, including ways to consider specific medications or biologics depending on specific organ manifestations, as well as a way to approach some of the comorbidity management with helpful references and links to additional information beyond the guidelines themselves. So hopefully this will help rheumatologists in management of lupus patients in the clinic.